Good morning. Welcome to session 233, medullary thyroid cancer, how to monitor with lab results and imaging, location of most common metastases, and how to find them with Dr. Whitney Goldner. Dr. Goldner is a professor of medicine, Department of Internal Medicine, Division of Diabetes, Endocrinology, and Metabolism at the University of Nebraska Medical Center in Omaha. She's a medical director of the Thyroid and Endocrine Tumor Program at UNMC Nebraska Medicine. Dr. Goldner has a clinical and research interest in thyroid nodules and thyroid cancer. She started the Thyroid Cancer Collaborative Registry, TCCR, at the University of Nebraska, and now is a principal investigator of the ICARE2, which I hope she'll explain, a multi-center bioinformatics and biospecimen registry for all types of cancer, which originated at the Fred and Pamela Buffett Cancer Center, University of Nebraska Medical Center. She has served on multiple committees of the Endocrine Society, including the Scientific Education Committee, the CEU Committee, Clinical Endocrine Education Committee, Trainee Committee, and most recently on the Board of Directors. Okay, I would like to welcome Dr. Goldner.
Thank you, Patty, for that nice introduction. And I want to thank the ThyCa organization for inviting me to talk today. So welcome to everybody. I wish I could see you all in person. We were just talking about how virtual meetings are great, but we do miss seeing everybody in person. So welcome and thank you for attending. What I was asked to talk about today is medullary thyroid cancer and kind of how to monitor. So I know you already received a talk on initial diagnosis yesterday and kind of, upfront treatment, and you'll receive a talk on systemic therapy tomorrow, and you've had some other more focused talks on other types of treatment. But what my goal is today is to kind of go from the journey from once you're diagnosed and have your initial treatment to kind of monitoring and what are the next steps and what to do. So I am happy to have this be an interactive conference. What I'll do is present if there's clarifications or things that I didn't explain very well. Certainly let me know, and Patty will let me know, and we can ask questions in the middle, or we'll just answer all of the questions at the end if there are none during the presentation itself. So, to answer Patty's question, ICARE2 is just the name of the entire thyroid cancer registry that involves more than just the thyroid. So it's just an acronym for Integrated Cancer Registry and Repository, because that was too long to say every time we said it. So thank you, Patty. All right, so disclosures is, I don't really have any relevant disclosures for conflict of interest, but just by way of introduction, I do work at the University of Nebraska Medicine, and Fred and Pamela Buffett Cancer Center here in Omaha, Nebraska. I'm a member of the NCCN Thyroid Cancer Guidelines and also the ATA Thyroid Cancer Guidelines, well differentiated, and I'm on the Board of Directors for the Endocrine Society. So I know that these were more extensively covered, but for those of you who may not have been able to attend the conference yesterday, just as a refresher, initial workup, we can't really forget, kind of the initial workup when first working at medullary. So just to briefly review, that's going to involve biopsy of suspicious thyroid nodules, cytopathology that looks suspicious for medullary, or sometimes it is a little bit harder to diagnose on biopsy itself, and you need more than one biopsy. Sometimes now with the recent advent of molecular testing of thyroid nodules, maybe the cytopathology or what the cells actually look like is not clear, but we might find a RET mutation on some of the molecular testing that gives us a clue that this looks like it would be medullary. So that's a relatively new thing in the last 5+ years. Genetic testing is very important if you know that it's medullary upfront. Testing for the RET germline gene mutation can help us know whether this is something that's sporadic or just has happened, or whether it's something that's hereditary. And the reason that's important, if we know about it initial treatment, is we want to make sure that we are screening for some of the other conditions that go along with medullary thyroid carcinoma if it is a hereditary syndrome. Most importantly, something called the pheochromocytoma, which is an adrenaline tumor that makes too much adrenaline hormone. Basically, it's and we would treat people with some appropriate medications before putting them through surgery. So that's why it's something that is important for us to know if we can ahead of time, so that we can make surgery as safe as possible. If we don't actually know the gene mutation status at the time of surgery, those are people that I would still test for this pheochromocytoma prior to surgery to make sure that they did not look like in their blood work that they had too much adrenaline hormone, or what we look for is called metanephrines or normetanephrines. Then once you have kind of that workup and the appropriate imaging to look at the neck and see how extensive it looks after you've had biopsies or around the time of biopsies, getting calcitonin and CEA preoperatively, if you know that it's medullary, can help dictate the extent of surgery, and then surgery is usually our first choice for treatment of medullary. So I know that's a very quick rundown of the talk that you had yesterday, but it sets the backdrop for then what are we going to do once you've actually had your initial treatment. So once you have had surgery, then staging is the next thing that we think about. Genetic evaluation, if this was a surprise, let's say you did not know it was medullary before you went to surgery, they thought maybe it was a different type of tumor, then that is important to do after the fact. Labs are going to be important to follow post-operatively. Imaging, and the type of imaging may be different for each person depending on what their stage, their calcitonin, and their CEA levels are. So it may be that no two people get exactly the same monitoring schedule. And then determine what we call the response to therapy. So what the response to therapy is once you've had your treatment, how well are you doing? And that gets assessed at each visit. Does it look like you're in remission, or are there things that we're monitoring that we want to see if they are changing or not, or dictate more blood work or more testing? All right, so first on to staging. So many of you may be familiar with this, but we use the TNM staging system. Tumor is what T is, and that's usually the size of the tumor. So you can see here a T1 tumor is 2 centimeters or less. A T2 tumor is 2 to 4 centimeters. T3 is more than 4 centimeters, and T4 is that it's grown beyond the thyroid. So that's just specific to the size of the tumor itself. N is whether there's presence of lymph nodes in the neck. And so if they're in the central neck right behind the thyroid, then we usually call it a 1A. Or if they extend into the lateral neck or kind of down into the chest, we call that 1B. So when you see TNM, those numbers will dictate or will kind of signify where actually the tumor was present. M stands for distant metastases. Now this can be confusing because sometimes people use the term metastases for lymph nodes, but in this case, we're not talking about lymph nodes in the neck metastases. That's where the N comes in. M just refers to distant metastases or something outside of the neck. And so that's just a 0 or a 1. If you don't have any metastases outside of the neck, then it's a 0. And if you do, then it's a 1. It doesn't necessarily dictate where they are. And so we put these TNM numbers together to tell us the overall stage. And you can see here, the bigger the tumor gets, the higher the stage, or the involvement of lymph nodes gets us a higher stage. So this is something that sometimes can be confusing because we may use the term, well, you had a T2 tumor, and sometimes that might be interpreted as stage 2. And if somebody doesn't have lymph nodes, then that may be correct. But sometimes if we are not very specific about indicating which one we're talking about. Is it a T2 or is it a stage 2? Or sometimes I've been asked, well, I had stage 3 cancer, but really what they had was a T3. They might not have as high a stage as they think. And so knowing both the TNM and then the overall stage can kind of help put that together. And what that does is it kind of predicts how extensive the tumor is and your risk of recurrence of it coming back. Okay, so as I mentioned, usually if we know that it's medullary thyroid carcinoma before surgery, then we recommend a genetic evaluation. But if it's not done pre-surgery, then doing it after surgery is okay. You don't necessarily, it can be done at any time. Now, medullary thyroid carcinoma is only about 3 to 5% of all thyroid cancers. So when you're looking at all thyroid cancers, it's not the most common. 75% of medullaries are sporadic, meaning there was no family history. They just happened without a known gene mutation. But a quarter of them are inherited. And they can be part of these multiple endocrine neoplasia syndromes. And there's a couple different types. MEN 2A or 2B, or where it's just a familial medullary thyroid carcinoma. And so those are ones that if you have that gene mutation, that can be something that is hereditary in the family. So because of that, all patients with medullary thyroid carcinoma should be at least offered genetic testing. That does not mean that they have to have it done. That's a personal choice and a discussion between the patients and the providers. But I think that it's something that should be at least available. And then that can be something that you decide on an individual basis, whether you're going to proceed with that. But because so many of them can be hereditary, and that can give us some information about not only other potential diseases that could go along with it for you, the patient, but also what risk your family has. Okay, so are all genetic tests the same? I find that this is a confusing topic. The more genetic tests that are offered out there, the more confusing it gets which ones we're actually testing, because a lot of times we use the terminology of like just genetic tests, and everybody's not meaning the same thing when they say that. So just a few definitions here. So when we're talking about something that's in your DNA, we call it a germline mutation. So that's something that would be in all the cells of your body, and that's something that can be hereditary. And so that's a blood test generally that you have done to see if you have the mutation, and then that's what family members would also have done to see if they have a similar one. What has recently been something that's been talked about a lot is these somatic mutations, or basically the tumor mutations. And so it's possible for somebody to not have a germline mutation, so they don't have it in their DNA, but they do have it in their tumor. Something happened to that tissue where it developed a mutation, but it's not something that will get passed on to relatives because it's only living in that tumor. And so that's what we oftentimes get when we're testing the tumor itself. So if you test the tumor either with a biopsy or after you've had your surgery and we test that tumor, that may be just a somatic mutation, but you don't actually know unless you've also had the germline mutation tested. So in that case, if you've not had your germline mutation tested, but you have the somatic mutation, I usually then recommend that they still have the germline tested to see if this is something that is hereditary or if it just happened in their tumor itself. And then as I mentioned, the testing that's done on thyroid nodule biopsies is somatic testing. It's tumor testing, not germline testing. Okay, so the germline RET mutation, the reason that that's something that, that we are interested in is because the type of RET mutation that is associated with medullary thyroid carcinoma determines to some degree what other conditions you should be evaluated for. So as I mentioned, the pheochromocytoma is an adrenaline-producing tumor of the adrenal glands. And so if you produce too much adrenaline hormone, that can be actually associated with high blood pressure and strokes and heart attacks and things. And so if we can remove those and know about those, that's much safer to take those out just for overall longevity, but certainly for the time of surgery. You can also have overactive parathyroid glands that regulate your calcium in your blood. So not everybody who has a RET mutation has these two things, but some do, and they have them at much higher rates than the general population. So we screen for them to make sure we're not missing something. It will also predict when you or your family members may need to start having an evaluation or even have their thyroids removed if you do have this mutation in your germline or in your family. So this is something that's in the ATA, or the American Thyroid Association, medullary guidelines. I only put this up here, not for you to memorize, but for you to show what I really like about it is it will show the different type of RET mutations that they have here. And then what their risk level is for various components of the syndrome. So MTC risk level, they've classified it as moderate, high, and highest. And then this dictates how young you might recommend somebody would have their thyroids removed to prevent medullary thyroid carcinoma from occurring. The genetics is a little beyond the scope of this talk today, and I know you probably talked about it in more detail yesterday with Dr. Busady and Grubbs, but I bring this up because I think it's really helpful to understand why this is important to us. The other thing that I really like about this table is it tells you pheochromocytoma and hyperparathyroidism, that's the calcium one. This is something called cutaneous lichen amyloidosis, and this is Hirschsprung's disease or some GI problems. And so you can see here, some mutations don't have pheochromocytoma at all, and they don't have hyperparathyroidism at all, and they don't have these other two. So you're going to be pretty low risk for getting anything else associated with that. However, look at some of these up here that have high incidences of the adrenaline tumors. Some have high rates of the calcium problems. And so knowing the mutation might help you know how frequently to screen for that. Okay, so what about labs? You've now been diagnosed, you have your pathology, you know your stage, and you may or may not know your genetics yet, but consider getting that tested. Next thing would be labs. And the first thing that we recommend is that you get a calcitonin and a CEA approximately 2 to 3 months after your surgery. Now, why do we check those two labs? So calcitonin is a hormone that is made by what we call the parafollicular C cells. Those are the cells that kind of turn into medullary thyroid carcinoma. And so if your whole thyroid has been removed and all of your medullary thyroid carcinoma is gone, we expect that calcitonin level to be quite low or undetectable. If you have recurrence or persistence, that calcitonin can be your biomarker or your tumor marker for whether things are going up or down. Now, CEA, carcinoembryonic antigen, is another tumor marker that we usually use with the calcitonin. However, it is not specific to medullary thyroid carcinoma, so we don't check that one all by itself. But the reason we check the two together is because they oftentimes can go hand in hand. And there are some tumors that if they stop making calcitonin, but they make more CEA, that can be helpful to know that. And so usually we check the two together. Most of them are going to go hand in hand, but some can be discordant. So that's why we always want to do them both. What about imaging? Well, the type of imaging is usually dictated by your overall stage and what your calcitonin and CEA levels are. So what imaging do we need to do to monitor for persistent disease or recurrence? So if they're low stage, so we've done their staging and they're low, and you have undetectable tumor markers or calcitonin and CEA and a normal CEA, then our suspicion of there being persistence or recurrence is going to be quite low, and you may not need a lot of imaging more than just looking at the neck. But if your calcitonin and your CEA is elevated, then further imaging should be done so that you can see where that would be coming from. In general, in the guidelines, if the calcitonin is less than 150, it's actually pretty hard to detect imaging evidence of disease. So sometimes your number might be elevated, but we don't actually see anything that looks abnormal. And that might be because there could be just microscopic disease that you can't see with imaging or the naked eye. And so that's why 150 is somewhat of a threshold for dictating the types of imaging that we do. So where's the most common sites of medullary thyroid carcinoma if it does leave the neck or you have recurrence? So overall, lymph nodes in the neck are still going to be the most common place that we would have extension to, and we would call that local regional, not necessarily distant metastases. But this is an example of an abnormal lymph node. And because it is common in the neck, the preoperative imaging and the preoperative calcitonin and CEA actually are really helpful in helping the surgeon decide how extensive should your initial surgery be. So if we see abnormal lymph nodes in the middle of the neck or in the side of the neck, then obviously we want that whole compartment that has those lymph nodes in it to have surgery and remove all of those. If the number is high, sometimes that in itself, the calcitonin number, might dictate how extensive they want that surgery to be so that they can remove as much disease or all of it if possible. If it spreads outside of the neck, lungs, liver, and bones are the most common sites for metastatic disease to be. Here's some numbers when people have tried to look at how common is this. So 33% of people who have metastases are estimated to have lung metastases, and they can actually be multiple small ones, or sometimes they can be bigger ones. Liver, they've estimated that they occur in up to 30% of just all comers, but 45% of people who have fairly advanced disease. And bones, the rates have been a little more variable, but have been reported in 19 to 54% of people. So what about neck recurrence? So the best way to monitor for neck recurrence is ultrasound. So ultrasound is no radiation exposure. It gives us great three-dimensional looks at structures in the neck. It can be done bedside and you can see it real time. And it allows us to actually look for little things like calcification or fluid or other abnormal features of lymph nodes in the neck. And so that is what we mainly screen with when we're looking for recurrence. And because medullary starts in the neck, that's going to be your most common imaging modality that we follow over time. It also allows us to determine if there are abnormal lymph nodes, then maybe biopsy them under ultrasound guidance. And if we do suspect that there's a recurrence, we usually send that for calcitonin washings from the needle that we do the biopsy with too, because sometimes it's hard to see the cells, but if there's calcitonin in a lymph node, that's abnormal, and that tells us that it looks like it's a recurrence. Now you can also do CT with contrast of the neck. That sometimes is a good adjunct to an ultrasound where you might suspect that there's deeper disease or structures that you really can't see as well with your ultrasound, or sometimes behind the esophagus or behind the trachea, or even behind the bones, you know, around your clavicles and things that it's hard to get a good look behind. So sometimes we do feel that CT neck with contrast can be a helpful adjunct, but I certainly don't do that every single time they have imaging. Plus it's radiation exposure that we want to minimize if we can control that. MRI soft tissue neck may give you the same cross-sectional look as a CT. However, in most cases, I would say that our surgeons and radiologists tend to prefer CT neck rather than MRI, but both can get the job done, especially if you can't have contrast for some reason with CT. So what other imaging needs to be done to look for disease outside of the neck? And when should you do it? So basically, preoperatively, if the calcitonin is over 500, you might have already had this imaging done because your doctor may have wanted to make sure that there wasn't distant metastases outside of the neck before they even did the first surgery. But postoperatively, that 150 is the number that we usually look at as far as, being the trigger to look for metastases outside of the neck imaging area. So how do we do that? So with the lungs, as I mentioned, those are one site of metastases that's fairly common. Usually we prefer CT chest with contrast. Now, just to look at the lungs, you don't need contrast, but to look at the mediastinum and in the center here to see if you have lymph nodes or central vascular structures, it is helpful to have contrast if we can. Now, some of them can be small nodules and just look like they are all throughout the lungs and may not be taking up much space from any individual nodule, but some can be larger or macro nodules and sometimes it can be a combination of both. The liver, the preferred study is MRI with contrast. Now you can also do CT with multiple phases of contrast, but at least at our institution and most that I work with prefer MRI if we can. That should also be done with contrast, because what you want to be able to do is differentiate between a metastatic lesion or a metastatic spot and other vascular non-cancer spots in the liver. And one of the things that's hardest to differentiate is like a bundle of blood vessels called hemangiomas. And so without that contrast, sometimes it's very difficult to tell the difference. What about bone? So bone is sometimes hard if you don't have any symptoms, because we obviously have lots of bones. And so if you have symptoms, then we obviously focus our imaging on that spot. So if you're having back pain or hip pain, pelvis pain, things like that. But sometimes you can do a whole body MRI that kind of does a scan of all of the bones with and without contrast to be able to almost do like what we call a skeletal survey. Now, the good thing about that is there's no radiation with the MRI, but sometimes not every institution has what we call the whole body MRI. So you'd have to get those all done as different tests, which sometimes is a lot of MRIs. So each hospital or each institution may be a little bit different in how they do the scans of the bones. You can also do that with almost whole body CTs, which again, not every institution has, but that's a lot of radiation also. So we try and weigh the pros and cons and see what's available at each institution. And certainly if you know there's bone metastases, then we focus in on those with usually MRI. What about other sites? Well, if somebody's having symptoms that make you suspect brain involvement, then MRI with contrast is the best way to take a look at that. And if there's some symptoms in the GI tract that you can't really evaluate with like an abdominal scan, sometimes you need a scope or an upper endoscopy to be able to kind of look directly at the stomach or the GI tract. And as I mentioned, there still are whole body MRIs and whole body CTs sometimes that some institutions will offer. So what about whole body nuclear medicine imaging? This is something that is emerging, and I believe you had a talk last night about the focused kind of radio-labeled octreotide as a potential treatment for this with Dr. Chen. So when they have looked at nuclear medicine scanning, they've looked at various PET scans. So the F-DOPA PET has been found to be the best one. It's got the best sensitivity and specificity, and in places like the NIH and some places in Europe where they've compared multiple ones head to head, it shows us the most spots of metastases when you're comparing all of them. The problem is they're very expensive and they're not available very many places. So not many people are able to just go have this done. But that has been the one that has been kind of emerged as the best one if you're trying to find all the spots. The normal PET scan, or what we usually refer to as a PET scan, is the FDG PET, where that's looking at your glucose activity in these spots. It's not great for staging, meaning you want to see exactly where all the disease is, because sometimes if the tumors are very slow growing and they're not turning over very quickly, they're not dividing very quickly, they may not light up on the PET scan because they're not very aggressive. So you might miss some that are very slow growing. It is better, however, for people who have more advanced disease or aggressive disease. So PET scans can be very helpful, but they're better for people who their disease is progressing more quickly. Just remember they can miss some slower growing spots. And then dotatate PET, that's a newer type of PET scan that looks at actually octreotide receptors on the tumor or somatostatin receptors on the tumor, because many neuroendocrine tumors, which medullary is a neuroendocrine tumor, they have these somatostatin receptors. And so it's not perfect, it's not as good as the DOPA PET, but what's really good about it is if you actually have the scan and you have your spots light up on this dotatate PET, that might mean that you would be eligible to having treatment, a radio-labeled treatment, meaning radioactivity hooked to somatostatin, and that used as a radiation treatment to target some of these spots. And so that's what Dr. Chen spoke about yesterday, and that's emerging as a possible therapy. So it can be helpful if that's one of the treatments that you are considering. So once we've done all of this, then you need to determine, okay, what is the response to therapy? So you know your stage, you've had your genetics eval, you've had your labs, and you've had all your imaging. And so now how do we decide where are things at and where do we go, from here? Well, the response to therapy is what kind of dictates the timing of your blood work and imaging going forward. No two people are really alike in how they would get monitored. So you want to know how that dictates what's the next best step. So this is a nice algorithm. I think you don't need to memorize this. I've circled in the boxes here. What I think is helpful is basically these are the ESMO clinical practice guidelines for medullary, and they go here saying, okay, you have your postoperative assessment with blood and imaging, and then you decide, do they have an excellent response? Do they have a biochemically incomplete response? Or do they have a structurally incomplete response? So this means we can see disease. This one means everything looks great. Blood and imaging is totally negative. And this middle one here, biochemically incomplete, is the blood work might be positive, but there's nothing on imaging. And you can see there's 3 different then pathways for what's next after that. When do you do your next labs and when do you do your next imaging? So we'll go through each one of those individually. So an excellent response is the ones where your imaging is totally negative, your calcitonin and your CEA are totally undetectable, or your CEA is normal. And so in this case, your calcitonin and CEA should be repeated every 6 months for a year because you've been newly diagnosed, and then yearly if they continue to be undetectable, and imaging if your calcitonin becomes elevated. Usually what I say is periodic imaging if it's been a little bit, but if your tumor markers have been completely undetectable, that's a good sign of remission, or what we call an excellent response to therapy. Similar to the kind of terminology that we use for papillary and follicular, where your response to therapy dictates next steps. Okay, what about a biochemically incomplete response? That's the one where your imaging is negative, but your calcitonin and CEA might be mildly elevated. So in this case, you do need to explore further and figure out, do we know where that might be coming from? So calcitonin and CEA should be done every 3 to 6 months to determine their doubling time, and I'll go over that in a minute, the calcitonin doubling time. Neck ultrasound every 6 to 12 months, because the most common place it's going to be is in the neck. And then, as I mentioned before, if that calcitonin is above 150, or I would also add if the doubling time is fast, then I would actually image other areas to look for disease outside of the neck. And then structurally incomplete response. That basically means we can see some evidence of either persistent or recurrent cancer by imaging, and your calcitonin and CEA are also elevated. So in this category, we want to decide, okay, is this stable disease? Has it looked the same for a long time? Or is it progressive or causing you symptoms? Because we might do 2 totally different things depending on that. If it is stable, and it has not changed for a while. I know if first visit, it's hard to know that, but over time, each time we're assessing this response to therapy, if it's been stable, sometimes active surveillance, meaning you're going to watch it closely and then determine treatment later, is appropriate. But you would do imaging at 3 months and then every 6 months as long as it's stable. And if it starts to grow, then you need to speed that up. You also want to check calcitonin and CEA every 3 to 6 months to again look at their doubling time and how fast is that changing. If they have progressive or symptomatic disease, those are the people that we really want to make sure that we're looking to see where it's at, determine its location, and decide what's the next best step as far as treatment goes. In general, if there's one area of disease and that's the one causing trouble, then we take care, you focus in on that spot. So if you can remove it surgically, great. If you can treat it with radiation, great. Do that and have it be focused so that you have a chance of it being in remission. If there's multiple areas of disease and they can't be treated with surgery or radiation all at one time, that's when you consider what we call systemic or basically whole body therapy, like chemotherapy or targeted therapy, because that would then treat multiple spots all at the same time. So what is the calcitonin doubling time? I've mentioned that a couple times, and that's basically how long it takes for calcitonin to double. So the faster it doubles, the more aggressive the disease is, and the more frequently you should be monitoring both blood work and imaging to see where that is happening and how quickly it's changing, and to determine treatment. Doubling times over 2 years have a very good prognosis. So if nothing has really changed or it hasn't doubled in 2 years, that's a good sign, but you still keep checking because sometimes that can become shorter and shorter over time. So with advanced or metastatic disease, no two people again are the same. So some can be very slow growing and not very aggressive. Others can grow rapidly. Some can secrete hormones. So sometimes if your calcitonin is very high, that can cause symptoms of flushing and diarrhea. And so those need to be addressed, as well as the spots that it may be located. And some locations can cause symptoms from the tumor itself. So you might have some bone pain from bone metastases, or neurologic symptoms if it's pinching on a nerve, or if it's close to important structures that we don't want it to invade in. Those would be reasons that we need to consider doing something more urgently. So how do you decide what and when to treat? So the need for treatment is determined by the scans, by the rate of growth, by the doubling time, and by the symptoms. So there's no, absolute when this has to be done kind of algorithmically. You need to balance the rate of growth and the side effects of the tumor versus the potential side effects of the therapy and the intervention. So we don't want to make it worse. And this should always be a joint decision between patients and providers involved, because it's not straightforward across the board. So this usually means it's a team approach of lots of experts in this area. So I am an endocrinologist, and I do the medical side of medullary thyroid carcinoma, but we couldn't do it without everybody involved. So the surgeons, obviously, the pathologists, genetic counselors, medical oncologists oftentimes get involved if there is metastatic disease and we're considering whether you need treatments for those metastatic spots, especially if you need some sort of systemic therapy or whole body therapy. Nuclear medicine radiologists to do potentially that radio-labeled treatment or do some of those scans. Radiation oncologists to do external beam radiation therapy. And interventional radiologists are radiology colleagues who know how to do procedures in radiology. And I'll tell you why that's the case. So what are the potential treatments? As I've mentioned, surgery, if we can take it out, that's always our first option. Radiation, if we can't take it out or we think that the spot that it is would be more amenable to radiation, that's what we do. Or liver-directed therapies, specifically if there's a lot of disease in the liver that we want to address. So I'm not going to go through these extensively, but to bring them up, so just so you're aware, there's a couple different types of things that we can do if you have liver spots that are growing and causing symptoms. So they can either ablate them with radiofrequency ablation or microwave ablation, where they kind of go in, they put a catheter in and kind of kill those cells. Or embolization, meaning they can actually put chemotherapy or things in the blood vessels that are feeding the tumors to kill off those cells. Now, the people who do that, though, are the interventional radiologists in general. That's who does it at our institution. And generally, these are only done if the liver spots are continuing to be a problem and not responding, say, to whole body therapy or chemotherapy or targeted therapy. They're usually part of a multimodal approach, and usually are not the only treatment somebody is getting. So what are some of the potential whole body treatments? So these are going to be covered by Dr. Dadu tomorrow in her systemic therapy talk. So I'm not going to go into them in great detail, but there's multi-kinase inhibitors, or some people call them TKIs. And there's a couple that have been FDA approved, cabozantinib and vandetanib. There's targeted therapies, meaning we actually, people who have that RET mutation either in their germline, in their blood, or on the tumor itself, might be able to get a treatment that targets that RET mutation specifically. Those are newer medications. And then there's the immunotherapies or checkpoint inhibitors, which have been newer treatments for lots of types of cancer. And they basically are emerging as a very effective treatment in some cancers. So again, I'm not going to go over them in detail. Dr. Dadu will discuss them, but just to bring them up as potential options. What about bone therapies? Well, if people are having symptomatic pain, say at a bone lesion, or if it's unstable or near something that we don't want it to cause a fracture or compression, we can give external beam radiation therapy. Sometimes if they're very small, we don't do that unless they grow. But one thing that is helpful is to actually reduce the bone turnover. So bone's normal life is it builds up and it breaks down, and it builds up and it breaks down. And so when somebody has a bone metastases or a spot in their bones, they're breaking it down faster than we want them to, and it could cause progression. So we then can give osteoporosis medications in a more frequent interval. So bisphosphonates, or sometimes you'll recognize it as zometa, or denosumab, that's Prolia. We give those more frequently than we do to people who have osteoporosis, and that slows down that bone breakdown, and actually has been shown to reduce the incidence of fractures and other things that happen from those involvement, the tumor involvement of the bone. It is, however, important to tell your dentist if you're taking these medicines, because they sometimes want you to stop those for a little bit if you need dental procedures, because if you're slowing down the healing of your bone or the turnover of your bone, if you've just had a tooth pulled, that can impair your healing. So always let your dentist know that. So what should your TSH goal be? Because you've had your thyroid removed and we need to give you thyroid replacement. Well, unlike the other forms of thyroid cancer, papillary, follicular, and Hürthle, we're not trying to make you a little bit hyperthyroid, because these are not thyroid follicular cells that respond to TSH. It can just be in the normal range. So it is important to have normal labs, but not necessarily making you hyperthyroid or a low TSH. Okay, so some of the things I want to leave you with here is, remember, no two people with medullary will have the same journey. Each person needs to have individualized evaluation and treatment, and collaboration and communication is key. So remember that this is a team effort with you and all of the specialists. And so I think that's when you're going to get the best approach to your evaluation and treatment. Okay, and so with that, I'm happy to take questions until we're done. Again, thank you for having me.
Okay, several questions have been put in the Q&A. Can you see those questions?
Let me see here. Okay, yep, I can see those. So, all right, let me see if I can unshare my screen so I can see you. I'm not sure. No, there we go. Okay, so yes, so I can actually go, I'll just start at the top. So from Rick, it says, are PET scans sufficient to detect MTC spread many years after surgery, or is more and different testing required? Okay, so yeah, so good question. So if it is very slow growing metastases, sometimes PET scans don't show those, because they may not have enough turnover or cell division to light up on the FDG PET scan. Now, some people, I guess the newer scans like the DOPA PET and the dotatate PET, if those have the receptors on them, you know, the somatostatin receptors on them, it's possible they would light up, but I wouldn't say it's 100% guarantee. So sometimes you have to combine cross-sectional imaging like CTs, MRIs, ultrasounds with that, with the nuclear medicine ones to make sure you've covered it entirely. Okay, the next one is from Sarah. Is there a chronologic order to Mets? Does it always start in the neck and then go elsewhere? Yeah, good question. I would say that so it's going to be in the neck most commonly, and that is the most likely place it will be for most people. So if it spreads outside of the thyroid, then into the lymph nodes in the neck, I would say there's no chronologic order once it leaves the neck. So some people, it may go to the lungs, some it may go to the bones. So it's hard to say where it would potentially go first after that. But yes, neck usually is the first place that it would be. Okay, next one from RJ Miller. If taking selpercatinib, and so just for the audience, that's one of the direct RET inhibitors, due to distant metastases to bones and quarterly calcitonin is staying under 10 and CEA is staying under 2, are CT scans necessary every 6 months or only if those numbers begin to rise? Okay, so yeah, that's a really good question because these drugs have not been out very long. So I think that we continue to learn as we go, how often are you going to have to image? So that might be a good question for Dr. Dadu because she actually runs a lot of these trials. I would say as a general rule, if the calcitonin and CEA and imaging have been very stable, then I do tend to reduce the frequency of how often I am doing them. One, to reduce the amount of radiation I'm giving somebody. And also, if it seems to be stable, then you can spread those out. So what I tend to do is actually keep checking the blood work, say, every 3 to 6 months, but maybe spread out the CT scans if, yeah, like what you said in your note, repeat those if the numbers begin to rise. So, but again, these are new enough drugs. I think we don't know everything there is to know. Okay. From Sarah, my total thyroidectomy with removal of 3 lymph nodes, stage 2 with a 4 centimeter tumor was in 2020, started tracking calcitonin. Levels are low, but okay, and doubling time is 6 months. Last ultrasound was stable. Next ultrasound, okay. Okay, so basically this question refers to low, so levels are low of calcitonin, but it's not undetectable. It is a little bit abnormal, and the doubling time is 6 months. So imaging of the neck has been negative, and what does that tell you? So this can be a really kind of vague and frustrating window to be in, where the calcitonin is mildly elevated. It's maybe creeping up a little bit, but it's not above that 150 mark. It may be that there could be microscopic cells that are making that calcitonin, and we just can't see them by imaging. And so I think that it's absolutely right to continue to monitor with neck ultrasounds. That's going to be the most likely place it is if that number is less than 150. And so it's it's exceedingly rare to find disease, really even in the neck or outside of the neck if it's less than 150 by imaging. But I do personally continue to check with ultrasounds when the calcitonin continues to rise, even in that under 150 mark. But it doesn't mean that you have to necessarily get whole body scans unless that calcitonin doubling time all of a sudden starts to really take off. And then I may not wait until 150 if it's starting to go up faster. And then the question is, should I have a central neck dissection? That's hard to say. So that's something that you would want to look at with your surgeon and your endocrinologist and see, are there any abnormal looking lymph nodes on your imaging? They may not want to just go back and take out the central neck without any imaging evidence of abnormalities, especially if the number is quite low, because you don't want to have another surgery and have them all be negative. Okay, Layla. Okay, recently given birth, congratulations, 5 weeks old, that's very exciting, and breastfeeding. Okay, and you're due for a gallium PET. Okay, and so how long do you need to stay away from your newborn? How far, and is the milk expressed while I'm radioactive? Good. Okay. Yeah, so all good questions. Usually we don't, again, we don't have a ton of experience with the gallium PETs because they are relatively new. I would say our nuclear medicine people would say with just a test dose of, kind of to do the scan, not a treatment dose, they usually would recommend a couple days to a week, by, kind of not being in close proximity to your newborn. Usually they say at least, 6 feet or more when you're talking about distance. Is the milk expressed while you're radioactive? Is it good? I don't usually recommend that you give it to the baby at all, just because the radioactivity there, I mean, whether they eat it or whether you touch it, there can be some radioactivity in there. So you could clarify with your nuke med person for sure, but I would probably discard it, is what I usually tell my people. Okay. Okay, so why do some people still feel not right even when TSH is in the normal range? So yeah, that's a complicated topic. So, and it's not necessarily specific to medullary. It can happen with anybody who's had their thyroid out for any reason, or actually is hypothyroid for any reason. So sometimes it's not just the thyroid that is not making you feel well. So I always make sure that we've looked at all the other possibilities too, because we don't want to just be quick to blame the thyroid and then have it be something that we just overlooked because we thought it was that. So the things I look at is, are you iron deficient? Do you have other vitamin deficiencies? Are you getting restorative sleep at nights? Lack of sleep can certainly make people feel horrible. So let's assume that you've ruled out all those things. There are some people who actually still with normal labs don't kind of feel like they're back to themselves. And in that case, there are a subset of people who tend to feel better if we replace both T4 and T3. I tend to do these as separate prescriptions so that you can do it more in the human physiologic ratios. But I have some people who actually feel better with the same exact labs by giving it to them that way. I have other people who feel like it didn't make a difference. And then in that case, it may not be the thyroid entirely that's causing that trouble. Okay, so next one is from Linda. Should there be urine testing for PHEO, please? So there are two different ways to check for pheochromocytoma. One is a blood test where you can get something called plasma metanephrines and normetanephrines. The other way is you can collect your urine for 24 hours and also check those things in the urine. And so you can do either one. They're both considered reasonable tests to do. Sometimes if one is positive, then they might do the other one if it's just mild to see if it's truly elevated or not. So yes, that's possible. Okay, next, Michael has a question about what's considered a normal TSH. So every lab is a little bit different in what their normal range is. Most of the time it's going to range from about 0.5 up to 4, 4.5. I would say when people are on thyroid hormone, most people will aim, if you're aiming to be kind of mid-normal, would aim to be more like in the 1 to 3 range rather than hang out on the edge of hypothyroid or the edge of hyperthyroid. But every person's a little bit different in where they're most comfortable. So I do have some people who feel better when their TSH is a little lower in the normal range, and some who really don't tolerate that. They feel hyperthyroid, so then they would like to run a little higher. So so I would say we have to evaluate it from a case-by-case basis. Okay, Wendy says, regarding the type of PET, with advanced disease, if a prior dotatate didn't show anything, is it worth trying again? Or should I go back to FDG? Oh, good question. Yeah, really good question. I'm not sure we know the answer to that. What I do know is, so the investigators at the NIH who have access to, say, all of them at the same time, because they're doing it as part of a study, they have, kind of reported that if you do all 3 tests, they're not going to all show the same exact thing. So theoretically, if you've had a dotatate and it was negative and nothing else has changed, say your number hasn't changed or anything, or no other imaging has changed, it's possible that going to the FDG PET would be would be, add something different, but I think there's no guarantee for that. And yes, you're right, DOPA PET, only places like the NIH or who have a test or have a trial for it generally have these tests available. Okay, next is Tom. So is MRI with contrast adequate for follow-up, or do you also need CT? Oh, good question. So CT of the lungs is the best way to image the lungs. So it's not real, MRI of the lungs is not our preferred method. So MRI of the abdomen would be preferred, CT of the chest, and then generally ultrasound of the neck, plus minus if you're going to add CT or MRI if you're looking for deeper structures. Okay, sorry. I think I answered that one, yeah. So Linda, if medullary and papillary, what should my TSH goal be? Okay, so a combination of medullary and papillary. So it kind of depends on what the stage of the papillary is. So if it is a microscopic small papillary that was just incidentally found, then you don't need to suppress the TSH because that's a low risk papillary. But if it's something that is a higher stage one and you would need TSH suppression because of the stage of your papillary, then I would go off of whatever the TSH goal is for your papillary. And I know that's being vague because there's many different goals, but it kind of depends on how big the papillary is.
We only have about 2 minutes left.
Okay, I will try and answer as many as I can. And Patty, just tell me when it's time to stop so I can get to as many as possible. I think I got Wendy's here. So, okay, Paula says, what are your thoughts on CI 19.9? So that's not something that I routinely check as part of medullary. So I guess I can't speak to that more. I would ask Dr. Dadu tomorrow and see if that's something that she ever uses for systemic therapy, kind of monitoring. Okay, next one is genetic test that was done. Genetic test that was done to determine if I had MTC was using saliva. Should I have a blood test done? Yeah, good question. Some companies offer saliva and some of them are good. So what I do oftentimes is I always ask our genetic counselors to look at what they had done and see how adequate the specimen looked like it was. And if it looked like they were able to actually test for everything, that would be looking at your germline or your DNA, then you may not need another one done, but you might want to just make sure that they got an adequate sample. Okay, Patty, how are we doing? Do I?
Maybe one more.
Okay. All right. I apologize to the rest who I can't get to. I'm trying to go through as fast as I can. Okay, one question is when to know to start zometa for bone mets. So what I generally do is if people have bone metastases, I actually do recommend that they do anti-resorptive just to decrease their extension. I know some people might wait until they're bigger bone mets and are causing troubles, but I tend to do that earlier in the course once I know they have them. So, okay. Well, thank you guys for all your great questions. I'm sorry I wasn't able to get to all of them. I don't know. I can try, and if you want to stay on the line, I can type an answer to some of the rest of you before you sign off, if that would be helpful. And then we can move on. So thank you again for attending. Does that seem reasonable, Patty, for me to type some?
I believe the format will sign us off automatically.
I see. Okay.
Yeah.
Well, I'll type as long as I can until it kicks me off. How does that sound?
Okay.
One person asked, I was on Fosamax for over 5 years and is now on kind of a drug-free holiday. That is something that we do. And so we don't decrease the bone turnover. And so I think that's reasonable. And usually what I do is just continue to monitor their bones every couple of years with DEXA to make sure they're not losing bone density also. And if their bone mets progress, then you might want to consider restarting it again. So somebody asked about, it looks like somebody's getting recommended to have a lower TSH. I would say if you really don't have any other reasons to have a low TSH, like papillary or follicular or something, then usually you don't need TSH suppression. It just needs to be in the normal range. And especially if you feel badly, I have a lot of people who feel badly being a little bit hyperthyroid. So that might be something to talk with them about. Is there a link between MTC and development of food sensitivities or gut issues? Sometimes I do know that calcitonin can cause you to have some GI distress. And so if it's calcitonin level related, that can certainly be something that I would look into, but I don't know of a direct correlation, but certainly a lot of people may describe symptoms. And so if you find that there are foods that make it worse, it doesn't hurt to avoid them and try and figure out what you seem to be sensitive and allergic to. Okay, somebody asked about, they actually had their thyroid removed proactively because of a gene mutation. Calcitonin is now low, no cancer in the thyroid. So because of the gene mutation, that would be something that you want to have kind of lifetime monitoring, but usually it's with tumor markers. You may not need very much imaging over time, because if there's no evidence of disease, it looks like they caught it before it turned into cancer. So congratulations. That's great.
Somebody asked if they want to be seen at your center, who should they contact?
Yeah, so we're the Fred and, actually you can see it in the picture back there, the Fred and Pamela Buffett Cancer Center. There's actually, you can look online, or the new patient, schedulers, you could call in at 402-559-5600, and that way we'll just get you to a scheduler, and then they would go from there.
Okay.
Okay, well, thank you again. You guys are a great audience, and I appreciate you guys staying on. And Karen, thank you for staying on longer. I don't want to run into somebody else's session, so I'm going to let you guys go. But thanks again, and I hope everybody has a fantastic weekend and great rest of the meeting.
Thank you very much. We really appreciate it. It was very comprehensive, and I know if we were live, we could have had
I know. Someday we'll all get to see each other in person again.
I know. Thank you so much. We really appreciate it.
Thank you too. Bye-bye.
Bye.